Brittany and I have chosen volume support as our mode of ventilation, and through this video we're going to explain the mode, the indications,
settings, and weaning,
and what we need to look out for if the patient is not able to be extubated. We're also going to compare it to pressure support. In order to explain our mode of ventilation of volume support, we're going to be using the Servo I ventilator. Volume support is a pressure support with a volume guaranteed. It is patient triggered, pressure limited, flow cycled. Some of the indications in order for someone to be put on volume support: patient needs to be breathing spontaneously. It is also used as a weaning mode, and it helps patients be extubated or removed from the ventilator. Patients have to have an inspiratory effort, but might need an additional support. The underlying disease of the patient should be resolved, or if not, improved.
In order to set volume support, you go to the drop-down menu, click on volume support, and then you have to set your tidal volume, your rise time, your FiO2, your PEEP, your trigger flow, and your inspiratory cycle off. Your tidal volume is set according to your ideal body weight multiplied by 5. The pressure is automatically increased to achieve a set tidal volume. The rise time can be adjusted to lengthen or shorten your E time, considering the patient's underlying disease. An example would be COPD needs a longer E time. Your FiO2 is set according to the patient's O2 saturation. Your PEEP is set to 5 to compensate for the lost FRC from the ET2. The trigger flow sets the sensitivity to the patient, and the inspiratory cycle off is what the patient has to remove from the vent in order to finish the breath. The ventilator gives a test breath with an inspiratory pressure of 10 centimeters of water pressure above PEEP for each subsequent breath. The vent calculates compliance of the previous breath and adjusts inspiratory pressure to achieve the set tidal volume on the next breath. No more than 3 centimeters of water pressure of change breath to breath. After you put in your settings, you'll click Accept, and then you'll go to your alarm profile and set your alarms. Your high pressure alarm should be 10 to 15 centimeters of water pressure above the pressure delivered, no more than 40 centimeters of water pressure. It will alarm if the pressure reaches 5 centimeters of water pressure below the set pressure. Your high respiratory rate should be no more than 35 beats per minute. Your low respiratory rate should be 2 to 3 beats per minute less than the spontaneous rate. Your high and low PEEP should be 2 above or below the set PEEP. And your minute ventilation should be 1 to 1.5 centimeters of water pressure above or below the spontaneous minute ventilation.
Parameters for extubation. The ultimate goal is to extubate the patient from the weaning mode. In order to extubate the patient, they have to meet certain criteria. One of the most known is negative inspiratory force, which we know as NIF. And NIF has to be more negative than negative 25. In order to do it in the Servo I compared to the other ventilators, we have to set the trigger flow, set it all the way down to negative 20. The patient needs to generate enough flow to reach this. So on your screen, you'll be able to see in the PEEP, you'll be able to see a negative number. So you add that PEEP to the negative 20 in order to get your NIF. And if it's less than negative 25, the patient is not generating that force. Another parameter we can also look at is the vital capacity. It has to be greater than 10 to 15 milliliters per kilogram. Another important parameter would be rapid shallow breathing index, which we know as RSBI, and it has to be less than 100 or less than 105. And the way we calculate that is respiratory rate divided by tidal volume. In other parameters, we also have to assess our patients and their vital signs. We're looking for respiratory rates less than 25. We're looking for adequate expiratory tidal volumes. We have to check their ABGs and make sure that they're close to normal to the patient. We also want hemodynamic stability. We don't want our patients on level-fed vasopressors, which are vasopressors. We also want, since they are spontaneously breathing, they need to be on minimal sedation or no sedation at all. We are also looking out for peak pressures to be low. If they are high, they should be we should consider to put them into another mode. We don't want to set our patients up for failure, so we also have to look for things that will indicate us that our patients are not doing well in this weaning mode. We also have to look for high peak pressures. If they are increasing, there is something changing in their lung characteristics, whether it is decreasing compliance or increasing resistance. So we can probably suction, or we can administer a bronchodilator. Their heart rate, if it is increasing over time also, we should also probably administer pain medication, or their anxiety is probably elevating. We also have to look at their heart rate if the patient is probably air hungry. We also have to look at the SpO2 readings and see how they're doing on this mode. And we also look for accessory muscle use, and there's a lot of factors that can also affect the weaning, and they could be psychological factors. The patient probably doesn't want to be extubated because they don't want to have, or doesn't want to feel the sense of not being able to breathe again.
Now we are going to compare pressure support and volume support. In pressure support, you set a pressure above the PEEP, and in volume support, you set a tidal volume. In pressure support, the patient also has control over the flow, the respiratory rate, and their tidal volumes. Pressure support prevents barotrauma because you have a set peak pressure. It also improves respiratory muscle endurance, and the less pressure support you have over PEEP allows more work from the patient.
Pressure support and volume support are weaning modes. In most hospitals, the one you see the most is pressure support. And that is just because most of the doctors, that's what they feel comfortable in. But volume support is as effective and can also be used in order to extubate the patient. So this concludes our mode of ventilation video.